Hello friends, you must have all faced problems in the fluoroscopy for the proximal humerus fracture. The problem mainly occurs when you are planning for closed reduction. While in open reduction, you have good view of the proximal and distal segments of the fracture, which you can reduce under direct vision and provisionally fix with K-bias and rotate the arm in internal rotation that can provide you the lateral view. But when you are planning for closed reduction and percutaneous K-wire fixation, you want the fluoroscopy to be in such a position that you need not to rotate the limb in internal rotation, because that is going to displace the fracture. For example, you are seeing you are getting good reduction in AP view, but the moment you tilt the arm in internal rotation to get the lateral view, your fracture gets displaced. So it is going to create problem if you are not prepared for proper fluoroscopy intraoperatively. So in this presentation, I will be discussing about some tips and tricks that are going to help you in getting lateral views whenever you are planning for the closed reduction and percutaneous fixation of proximal humerus fracture. These views are also good for open reduction, so they can be used either in open or closed reduction just to make things easier. So whenever we are planning for open reduction and internal fixation, our fixation is stabilized provisionally with K-bias and later by the plate, so we can rotate the limb without changing the C-arm position. So you see, without changing the C-arm, we are getting AP view as well as lateral view just by rotating the arm. And since the fracture is reduced and in stable position, that's why the reduction is not getting hampered. Now suppose you are planning for percutaneous fixation of proximal humerus fracture. In this case, you see there is combination here, there is varus tilt, there is extension. This part is anterior, this part is posterior. So there is extension at the fracture site and there is increased retroversion of the proximal fragment. But if we are planning for percutaneous fixation of this fracture using K-bias, we want fluoroscopy in such a position that we need not to change the reduction maneuver. Suppose the reduction comes in abduction to control the varus, and flexion to control the extension, and slight internal rotation to control the external rotation of the distal fragment. So we want the lateral view in that particular position only. If we are rotating the limb in extreme position to get lateral view, that means we are going to change the reduction also. So what we normally do, we position our C-arm either proximally at the head end or towards the foot end to get the AP view. So usually the problem does not occur when we get the AP view because the shoulder is lying directly orthogonal to the beam of the fluoroscopy. We get an AP view like this. Now before proceeding towards the surgery, we always need to ensure that the fluoroscopy console is positioned adequately. Why? Because often our operating tables have metallic edges in this area, and these edges are going to obscure your view. So the position of the patient needs to be adjusted according to these metallic edges, as we'll be seeing in the coming slides. For example, you see in this image, the metallic is obscuring the view of proximal humerus. So the patient either needs to be shifted on the outside area or toward the inside area, which is radiolucent. So these things should be kept in mind before proceeding to the surgery. So while there should not be any problem in AP view, we often face the problem in lateral view. The C-arm console can be placed from the head end or from the foot end and needs to be placed under the arm. That means it should be facing axilla or shoulder, and the arm should lie in this area. So there should not be any problem in abducting the arm to get this clear space for placing the C-arm console, because the abduction position is actually helpful in reduction, as it is going to relax the deltoid muscle and also going to correct the varus malreduction. But you see, the console beam is going to pass through the shaft of humerus only. We are going to miss the proximal humerus in our view. So if we have placed the operating part of the C-arm in this area, then we are going to face difficulty in getting the axial view or lateral view, because the C-arm technician is going to come in this area and he is going to make your limb position difficult, because you want to stand here to keep the limb in particular position. So we don't want the operating area of the C-arm in this area to get the axial view. So to get the proper axial view, to keep this part of the proximal humerus in the direction of the fluoroscopy beam, we want to tilt this console to this direction. That means this part should come somewhere outside here, while this part should go somewhere here. Then the fluoroscopy beam is going to pass through the shoulder. So the problem occurs when the operating part of the C-arm is in this area. That means the technician is standing here. He will have to come outwards near your equipments, instruments and operating trolley, which is going to create problem. So we don't want the operating part of the C-arm and technician in this zone. That's why it's better to keep your C-arm at the head end, because it will provide good space for the technician and the operating part of the C-arm, and only part you'll be getting in this area is the terminal part of the C-arm. That is not going to take much space and it will be easy to get the axial view. So this kind of view we will be getting if the C-arm is placed like this. So we have to rotate it like this, and whole of the operating part of the C-arm should lie on the head end. But again, you see some problem is there. Why? Because the head of the patient is obscuring the view, because it is coming in line with the shoulder. So what we can do, we can either tilt the head away from the operating side after telling the anesthetist. They can position the patient's head accordingly, and we can slightly pull or lateralize the proximal humerus in this direction, like this. So we are now getting a better axial view, but you see some part of the head is still obscuring the view. So what we can do to improve this, we can slightly tilt the console in upward direction at the head end. What it will do, so the beam will now not be blocked by the head, it will directly come over the shoulder, and you see we are getting a good axial view which is not obscured by the head of the patient. So slightly tilting the C-arm upwards can definitely help you in getting good axial view. So this should be the position of the C-arm whenever you are planning for close reduction, because in close reduction you don't have the scope of rotating arm internally to get the lateral view. You want to rotate the C-arm to get the AP and lateral views for you. So this should be our final position. The C-arm, console and whole of the operating part should be there on the head end, and the terminal part of the C-arm should come between the upper limb and the trunk of the patient. So by that you will be getting a good AP view as well as axial view. And for open reduction also you can use this assembly, that is going to be helpful for you. So in real life the assembly should be like this. You see whole of the operating part of the C-arm is lying on the head end, and the C-arm beam is passing slightly above the head, and it is passing through the shoulder whenever we are getting the lateral view. So the head part is not obscuring the view, and when you see from the head end there will not be any problem in the AP view, and whole of the anesthetist assembly is lying on the opposite side of the operating table. So you are getting good space for the C-arm as well as for the anesthesia assembly and for your operating area also. So what if the OT table has a problem of metallic edges that are obscuring the view of the proximal humerus? What you can do, whenever you are planning for the open reduction, you can slightly tilt the patient on the opposite side. You can do like this. So if this part is radiolucent, then there should not be any problem in getting all the views, because if you have committed for the open reduction, then definitely you are going to reduce the fracture under direct vision and will be securing it with K-bias, and there should not be any problem in slightly rotating the limb in internal direction to get a lateral view. But if you are planning for close reduction, that means you want an axial view which should be there without rotating the arm. So what you can do, you can slightly tilt the patient away from the metallic edge. So the shoulder part should now be free of any metallic edge. Additional points should be taken care whenever you are operating the patient. If you are taking the patient slightly inwards, always keep a thick sandbag underneath the scapula. Why? Because that is going to lift the shoulder above the level of the table, and you will be getting a good axial view because it is not going to get hindered by the surface of the table. As we discussed, the metallic edges is going to obscure our view. If the shoulder is free of this metallic edge, you are not going to face difficulty in getting the lateral view. Also, whenever this part is pushed by the table, you face difficulty in reducing the fragments. So always keep a sandbag underneath the scapula. That is going to make whole of this shoulder part free of any pressure from posterior direction. So I hope this video will be helpful whenever you are planning for operating the proximal humerus fracture. If you have any queries, you can just put those in comments. I will try to resolve those queries with the help of examples if needed. Thank you.